So again, good afternoon, everyone, and welcome to today's Pediatric Readiness Recognition Programs Collaborative Session. Today will be our 12th session. And before we get started, we would like to acknowledge that the Pediatric Pandemic Network and the EMS for Children Innovation and Improvement Center are supported by the Health Resources and Services Administration, which is within the U.S. Department of Health and Human Services. The contents are those of the authors and do not necessarily represent the official views nor an endorsement by HRSA, HHS, or the U.S. government. And as a reminder, today's session is being recorded and will be posted to the EIC's website along with today's presentation. And as always, we look forward to having an interactive session with you all, so please feel free to raise your hand or come off mute throughout the presentation. Like our last two sessions, we will focus today on hearing from you all about the work going on related to the creation and expansion of pediatric recognition programs within your states. So without further ado, we will hand it over to Illinois to get us started. And I will go ahead and stop share so you guys can.
Oh,
That's okay. Or I can continue.
no, it's okay.
Okay.
Okay. Can you see my screen?
Yeah, they're there, Kelly.
Okay. Is it showing up in the present? Oh, hold on.
No, it's still
There we
showing.
go. I had to move it to being able to edit, so.
Well, good afternoon, everyone. Next slide, please. We're going to start out with just providing an overview and demographic information, and both myself and Kelly will be co-presenting this section. So Illinois has a population of 12.6 million with over 2.7 million under the age of 18. The map shows our state divided into 11 EMS regions, which we'll touch a little bit more on shortly. In 1994, our EMSC Advisory Board convened a Pediatric Facility Recognition Task Force, and they were specifically charged with assisting the state in developing requirements for a facility recognition program. And then in 1998, we were ready to conduct a pilot, and we did that in an urban and a rural region. There was really a lot of interest at that time, and because we approached this on a regional basis, many of the hospitals in each region felt that they were in this together, so this had a real positive effect on participation. Now, we have 185 hospitals that have emergency departments in our state, and there are currently 105 that participate in our facility recognition program. On the map that you see, each region, because these are considered EMS and EMS regional breakdown, so each region provides oversight to pre-hospital and trauma services within their given region. And so our EMSC program uses this same regional structure. Just to provide a perspective on the map, the regions in the upper right corner, which are regions 7 through 11, those are primarily urban and suburban, and they're the most densely populated regions in our state. The rest of the state is pretty much rural with some urban pockets. We started our rollout of facility recognition with phase 2 levels of recognition. And those focus primarily on the emergency department. And then after a few years, we had worked on criteria for a 3rd level, which is our top level, and that refers to the pediatric critical care centers. That level goes beyond the doors of the emergency department, and it focuses on the pediatric intensive care unit and the pediatric inpatient area. The pediatric critical care centers play a critical role in our facility recognition process, particularly in receiving transfers from the community hospitals. So we really wanted their involvement in our state program. And we now have the numbers that you see on the slide here represent the number of hospitals that participate at each of those levels. And all of our requirements are integrated into state regulations. Next slide. We revisit hospitals and we conduct renewal site visits every 4 years. So each year we concentrate on 2 to 3 regions and conduct in-person visits. And then it takes us 4 years to get through all 11 regions. And then we start the process all over again. So This approach really allows us to manage the renewal process in an organized fashion. And you can see on this table, each of the regions then has access to their regional schedule. We're currently in the 6th renewal cycle of renewal, and this whole process is completely transparent. Hospitals can access this schedule on our website, as well as access all of the materials, which Kelly's going to go through shortly. Any new application, so if we have hospitals that are currently not participating, but they'd like to apply, they can apply at any time. So they don't have to adhere to any set schedule. So there's no specific time frame for new applications. And we anticipate using a similar structure with our EMS agency recognition program. Next slide. This slide shows our organizational structure. So we have our EMSC program is based within our state Department of Health. We have a 25-member EMSC advisory board, and that board provides guidance, and also reporting up to that board are 4 standing committees that are charged with specific areas of focus. We do have ad hoc committees that we pull together and form as needed when we have specific areas of focus. For example, during COVID, we had a task force or an ad hoc committee that focused on the MISC and developed some resources and guidelines related to that. The facility recognition task force from our early days that I mentioned eventually evolved into a standing committee, and that group continues to meet today. And then for our pre-hospital recognition program, that's being charged to our pediatric pre-hospital committee. The advisory board composition and the responsibilities of the board are outlined in state regulations, and the board also has a set of bylaws. So that's an overview of our structure, and Kelly will now review in more detail specific processes that we utilize that have evolved over the past 26 years. Thank you.
Thank you, Evelyn. So as Evelyn said, I'm going to start touching base on some of the program details. And with our program being as longstanding as it's been, we wanted to not just give an overview of how our program runs, but really kind of focus in on what's helping it to continue to run and be successful. So we really try to, Evelyn used the word earlier, transparency, and that's so important. So we want to make sure that we have a centralized location for all of our information about our recognition program, as well as access at any time to our application documents and links to all of the resources that can help hospitals be successful. We are very supportive of our hospitals. And even though we are that regulatory program, we have that shared goal of decreasing morbidity and mortality. So providing support is such a positive interaction for our hospitals. Additionally, in order to keep consistency throughout the process, we've really worked to ensure that we have standardized forms. And all of these forms go through our committees and work groups to make sure that they're aligned not only with our administrative code, but our current best practices, or as well as any updates, such as the joint statement that came out regarding the list for pediatric readiness. So ensuring that we are up to date with those current best practices. And we review these regularly and update as appropriate. We also work to make sure that we are providing user-friendly documents, so everything provides a ease of use. Our application documents, which we do have snippets here on the screen, are interactive and fillable forms. So just for example, the piece, let me pull my mouse over here. This particular piece right here, credentials of emergency department nursing staff. We have different credentialing forms, but they're able to add or subtract lines as needed so that it is appropriate to the number of individuals they have. All of our documents as well, our checklists, they do follow along with our administrative code requirements. So as you're going through the code and you're following your checklist, you're able to say, oh yes, this is the code, this is the policy, I need to make sure this is in here. So it's all very easy to follow. It's just right there for the hospitals. Another thing, oh, I'm sorry. got a little excited. One of the other things that I wanted to point out here, there's a couple screenshots here of what looks like file folders. And so we have recently worked to make things easier to share and cut down on the amount of environmental impact we're making. So we have utilized a Microsoft OneDrive process, and we built a folder system within OneDrive that aligns with our checklist and the tabbed dividers that they get for their paper copy of the application. So now they only have to submit one paper copy, and then they're also uploading the documents here, which makes it really easy to share with the surveyors. So they have a chance to look at the information prior to the survey, and we're just able to, have everything much better organized. Okay. So, moving on, additionally for the program, not only having that consistency, but having a way to track and communicate easily. So we have recently moved from a Microsoft Access platform to utilizing a Smartsheet for our database. And what this is as we do an application review of all the documentation submitted. So then we put that into our database so we have that to look back on if needed. But that also then it works to generate a letter that goes out. So what I have here on the screen is just showing a document, just a snippet of the database, and then a screenshot of what the letter looks like or the document that's generated looks like. And this follows right along with the checklist. So there's just consistency in the structure of how everything goes, which just really adds to that ease of use. I mentioned earlier, and as one of the icebreaker questions, just that support to hospitals is so important and beneficial. So throughout the longevity of the program here, ensuring that hospitals are able to be successful, a big key part of it is education and resources. And we have developed guidelines for the application process, guidelines for the actual survey process, educational webinars that we do, in addition to our in-person webinars, depending on whether it's an application or the survey process review. And then we've also done a similar thing for our surveyors, where they have an actual set of guidelines as well that they're able to follow along and know what their expectations are and what they're specifically looking at. So it's been really, really beneficial to have this out there and consistent for all of the individuals involved with facility recognition. We do make sure that we look at these before every cycle. As Evelyn mentioned, we're doing 2 to 3 regions a year. So in the fall or in the spring and then in the fall. So every spring before we get going, we're reviewing these and making sure information is current. And again, in the fall. So there's a lot of work to keep this up to date and make sure that we're sharing the appropriate information. So we've spoken a couple times during some of our Midwest EMSC or our Great Lake regions, and I think even a little bit here within our federal groups and at the grantee meetings. But we, in order to not fall behind and have this huge gap during COVID, we had to look at how can we continue to support the hospitals and do facility recognition during COVID. And so we did delay our surveys from our spring to the end of the summer. And we did this by transitioning from in-person to doing a virtual survey. And while it functioned, we did learn that there were some barriers for us on that. First and foremost, on the state side, there was a whole lot more planning. It kind of feels like it had almost tripled our efforts. There were a lot more emails, documents going back and forth, scheduling and tracking that had to be done. But then on the hospitals as well, they had a significant amount more work that they had to do. There was additional documentation. They were asked to submit photos of equipment and supplies, disaster areas. And they were even asked, they were given a rotating list for each hospital. We would identify like 5 items off of the equipment, medication, and supply checklist that they showed us over the camera. So it was random, so not everybody knew it was these particular 5 items, and we could check different equipment pieces. We also found that, part of the thing that we've all learned through COVID was there was a loss of continuity and a great amount of staff turnover. And even though we're a few years of kind of getting back into a normal routine post-COVID, we're still seeing that there's just been this loss of the continuity of operations. And as a result of that, there was a gap. There's a definite recognizable gap. And it really focuses in on the quality improvement pieces of the facility recognition program. And then we also had an inability to visualize some of the different equipment items. And we found when we came back in person and we'd be doing our tours and validating equipment, that there were several times that the crash carts, their pediatric resuscitation carts, dusty, disorganized, people didn't know where things were. So you're seeing that, as coming out of COVID, there was this gap because there wasn't somebody that was really staying on top of things. And we feel that there's a chance, had we been able to do these in person and not had to have gone to the virtual, that there wouldn't be that gap, several years later. Some of the benefits we do find coming out of the in-person survey process is it really does give us that ability to build better relationships with the hospitals, especially those key individuals like the pediatric quality coordinator and the pediatric physician champion, which here in Illinois, those are the terms that we've designated for that PEC. We're able to really get a better understanding. We can see their pediatric processes better, how they put things into practice. And we often get to see things that we wouldn't see if we're doing something virtually, such as the background of this is a QI board. And this one here is focused on patient education that they give out. And when you're doing a virtual thing, this is not something that they can just easily show you over a camera. So for us, we really feel like there's so much benefit, especially when our surveyors, we can leverage their subject matter expertise and give just-in-time feedback and collaboration and best practices as well. So as I mentioned earlier, even though we are a regulatory body for our program being from IDPH, we really strive to support our hospitals to ensure they have the capability to meet requirements and be successful on their path to pediatric readiness. Just a couple other things on program longevity. Again, that transparency for hospitals as well as really anybody to be able to see what's going on with our facility recognition program is utilizing our IDPH website, where individuals are able to actually go on and they can view an interactive map or a list that can be exported into an Excel spreadsheet on all the hospitals that are recognized and what level they are. On our longevity, we really, through all of these processes, are working to, on our state side, show that we've got a continuity for our operations, utilizing a database and way to track our program participation. This also gives us a really easy way to ensure that we are able to do record retention, have an electronic as well as paper version, so there's always a backup. And it does help us meet the needs if there is a request for a Freedom of Information Act to be filled. The one thing I do want to mention on that, though, is be aware of your state's record retention and disposal policy, because that'll help you with that record keeping process, as well as what the response to a FOIA request is, and ensure that you're really working with your own legal department so they can determine the release of documentation. Okay. Moving forward, our next steps for our program is we really want to leverage our relationship with the Illinois Critical Access Hospital Network. They are working to encourage the non-participating hospitals that are critical access to take the steps for pediatric readiness, especially by minimally identifying a pediatric quality coordinator or a pediatric physician champion. We also are collaborating with our pediatric pre-hospital committee, and they're going to be helping take that lead on the development of our pre-hospital readiness recognition program. So thank you so much for your time. If anybody has questions, Evelyn and I would love to answer that for you now.
Thank you so much, Kelly and Evelyn. Any questions for the team from Illinois?
Hi, Kelly. Michael Kim here from Wisconsin. How are you?
Good, how are you?
Good. Hi, Evelyn. Hi, Evelyn. How are you? Well, you guys are, lifetime ahead of everybody else, and really, it's nice to hear how far you've gone in the last, 10, 15 years since we've talked. I have many, many questions, but two main questions. So, the funding for this program is one thing, and the other is, how are you able to credential, or at least to verify all the EDs that are involved by region? It just seems like a daunting task to be able to do so many EDs at once, but how do you work that out?
So, yeah, I mean, essentially, in the early slides that were presented, we do it on a region by region basis. So that we found works best because then we're focusing on one geographic area, a couple of geographic areas at a time. So each year we have 2 to 3 regions that we're focusing on. And that way we know exactly where we're going to be doing our site visits. We can work with our physician and nurse survey teams and get them geared up as to where we're going to be targeting that area of the state. And like I said, it takes us 4 years to get to 11 regions. So each hospital is surveyed on a 4-year cycle, but each year we're addressing 2 to 3 regions.
Yeah. And I would also add that, yes, there's 105 hospitals that we're doing, but because we do it set up as this regional approach, the number of hospitals that participate in each region it kind of averages around, we're doing like 10 or so per survey cycle. Some of the regions have a very small number of participation. We do 2 surveys in a day, typically, one in the morning and one in the afternoon. Our pediatric critical care survey, so that includes looking at the PEDS unit and the PICU, those are scheduled for a 4-hour time block, and our EDAP and CDAP are 3-hour time blocks. So we are able to do 2 in a day, and thankfully we are able to address the schedule so that we can drive, reasonably between the 2 surveys.
And by having a survey team, you're able to divide up the amount of work so that even though the amount of hours that we're at a hospital seems like a small amount, we're very much on schedule in terms of when we need to start and finish, what each person is going to focus on. And then there's a lot of documentation that is submitted ahead of time. So we've already done some pre-leg work in reviewing their documents. And then when we get there, there's a number of documents that we ask them to have available for us to review as well.
That seems like a very seamless process. But the biggest question is, how is this all funded?
So both Kelly and myself are funded by the state. So we've been very fortunate to have that support through our state program. And then we utilize our grant to provide honorarium and travel reimbursement for our survey team members.
Mm-hmm.
And then, like Kelly said, our committees are involved in helping to develop resources, educational modules, and guidelines to assist.
What other questions do we have for Kelly or Evelyn? Right, I don't see any in the chat, but if you do have questions down the line, feel free to put them in the chat, or we can address them at some time at the end as well. Thank you again, Kelly and Evelyn, for sharing. Right, next we have Oregon. Would you like to share slides, or I can share them for you?
Sure, if you want to share them, that'd be great. Thanks. Hey, everybody. Gonna talk a little bit about what we've been doing to prepare to have a pre-hospital pediatric readiness recognition program. Next slide. So we are in the development stages of a single level pre-hospital recognition program. It looks like it'll be called Peds Ready EMS. And starting in late 2023 through early 2024, I requested many state examples. So thank you all of you states who provided your outstanding examples of your programs. And we took those examples and pulled from those kind of the best of each, and then also looking at the HRSA guidelines to draft an application guide, and an FAQ, and that happened kind of middle part of this year. And then just last week, we shared the documents with the EMSC Advisory Committee and requested their feedback. And they had some really nice feedback for us, and we'll be making those adjustments. Next slide. So a little bit more about the program. So again, we got that document or those documents reviewed and got feedback. We built the application in Smartsheet. We felt like that would be the easiest place to manage it. And the agency point of contact will complete all the required fields. And then once it's submitted, myself, and hopefully I'll eventually have more than myself, but for now, I'll be reviewing the applications for completeness. And then if there's something missing or it's unclear, then I'll be requesting clarification or requesting more documentation. And then for the recognition process, once agencies have completed their application, they'll receive a certificate and then a decal for each of their licensed ambulances. And that initial recognition will be for up to 2 years, and then it'll be open for renewal after that. Next slide. So just a few next steps. We'll be refining that application and supporting documents based on the EMSC Advisory Committee's feedback, and then drafting the certificate and decal and getting those printed. And then sharing final documents and the certificate and decal with the EMSC Advisory Committee. And this is going to be slightly tricky in that our state just passed some EMS modernization legislation, which is forcing us to kind of reboot our existing committees. So all the people that are sitting on my committee right now, they met for the last time as that group in October, and it'll be restarted in February of next year. And some of the members will be the same, likely, but there will be many new faces as well. So they may or may not have ever heard of this. And so we'll kind of be starting over a little bit and explaining to them about how it works and what it is and all of that. So more to come on that. And then in March, we're hoping to launch the program. Next. Yeah, and so that's my contact info, and if anybody has any questions.
Hi, Rachel. Michael came again from Wisconsin. How many EDs do you guys have, and how at this point, how many applications do you have, and just what's the initial process?
I think I missed the first part of your question. Did you ask how many EMS agencies?
Oh, how many EDs do you have in the state?
Oh, this is not an ED program. This is for EMS.
Oh, it's an EMS program. Okay. Yeah. How many EMS agencies do you have?
Transport agencies that we license, it's roughly 135.
Thank you.
Hi, Rachel, it's Julie. I have a question about your, we'll call it a barrier maybe, or a little setback with your legislation being changed and the group being changed. You have a launch date of March, which is awesome. Sounds like you're going to continue with that goal of the March. Do you anticipate any barrier to launch because of the legislation? And then my other question, I'm going to turn it around to the group. Has anybody else experienced this? And do you have any information or helpful hints for Rachel from your experience of the any kind of change right before launch?
I'll say fortunately, because I was able to assist with the drafting of the legislation, it includes a recognition program in legislation. So it will actually be in statute that we have a recognition program. It remains voluntary, but at least it's in statute. So it's not as if I'm coming out of left field with it. It is a known thing at this point because people have seen what was passed. And it mentions in the bill about not only the pre-hospital program, but the ED program, which actually right now the language is a little wonky, but we are requesting a language fix on it because it's like almost right, but not quite right. As with a lot of things that get passed, legislators don't exactly understand what you do. So hopefully we can get that fixed. Any other questions?
Like Pat has her hand raised.
Hi, Rachel. My experience with having these programs in statute is that it always, is the issue of funding comes up, and also the ability of in statute, whether you have the authority to recoup some of your costs associated with management of the programs as far as that's concerned. For example, in, when I was EMS director for Contra Costa County, and we had statutes regarding, legislation for STEMI and stroke and programs and that type of thing, the county EMS agency had the authority to basically create a fee structure that would basically help sustain the program. Can you share a little bit about anything in that direction, or any thoughts in that area?
Right now, there's no fee structure in the bill. It was interesting. I would consider myself a novice when it comes to legislative stuff, but in sitting in kind of as an outsider, well, not an outsider exactly, but just sort of listening in listen only mode in those meetings, it was interesting to hear the legislators talk about, so there's no fiscal attached to this kind of question mark. I think there was a lot of push to get something passed, and without a fiscal, that means, as you know, those of you that have been around a while, that means you can't get extra FTE. That means you can't, you have no other monies to allocate to any program. So as you've mentioned, it's complicated. And yeah, I think we'll see. There's going to be another round of like proposals that are going to go forth to the legislature for this next session. That's a hard word to say. For this next session. And so I'm hoping that there is a fiscal attached to that and that we can actually get moving on some stuff.
Yeah, I mean, the issue with things in statute is that stakeholders, all the stakeholders, become highly sensitized to another unfunded mandate. And so there are significant politics associated with trying to move forward, any types of programs as far as that's concerned. So I would recommend looking at what your state has done with, recognition programs like STEMI and stroke, trauma, that type of thing, and align with those types of models in terms of language in statute.
Yeah, they passed a whole gamut of new programs at the same time: stroke, cardiac, all the things. So it's all new in the zoo. And so we will be, there's a bunch of us, current staff that are kind of in the trenches together. So we're figuring it out for sure. And I'm optimistic, but yeah, we'll see what happens. Any other questions?
Thank you so much, Rachel. And if you do have questions, feel free to put them in the chat, and I'm sure Rachel wouldn't mind helping to address some of those.
Yeah, no problem. Thank you.
Thank you. Next up, we have Tennessee. Would you like to share your slides, or I can share them for you?
You can, it's fine.
All right, take it away.
All right, next one, please. All right, I'm Tasha with Tennessee. So we are currently working on our EMS recognition program. Last year, after we got our performance measures, I went and I met with our EMS director and some of his staff, his surveyors and people that would be involved with this program, and got their blessing on moving forward with it. And so I took it to our advisory committee, which our advisory committee is set up a little bit differently. We have about 50 people who are voting members. We call it the Committee on Pediatric Emergency Care, COPEC. And we have a subcommittee, which is the EMS Standards Subcommittee. And I asked them to basically devise what our program would look like. So they came up with a 4-tiered program, and they used the pre-hospital pediatric readiness checklist to create all of the requirements in the 4 different tiers. So at the bronze level, each service will meet minimum requirements, which will include like a PEC and things like that. And then by achieving the platinum, then the EMS agency would have completed everything on that checklist. And they were very cognizant to make sure that it would apply to both EMS and fire services. And they'll be able to grow and change as we learn things and legislation changes and things like that. So one thing that our EMS director did request is that it would be a voluntary program. And so that's how we're moving forward with that. Can I move to the next slide, please? All right, so again, our advisory board is our COPEC, asked them to review and create it. They took several meetings, put it together. After that point, they went through and we went and got it validated through several different constituent groups, went to the director association committee. So in our state, we have 8 EMS regions. And so each region has their own directors association. So it was presented to all of them. And we also presented it to our PEC meeting. We hold that quarterly. And so we got some end user feedback on it as well. Application, there's not going to be really much of a true application process. They're just going to let their surveyor know. So the surveyors from the EMS office, when they go out and survey for their license renewals, they'll just ask them if they want to self-designate at a certain level for this program. And if they do, then they will have a checklist that our EMS subcommittee is currently working on creating that the surveyor can use to make sure that they meet all of the requirements for that level. I think that kind of covers here. So the recognition program, again, the surveyor will then let us know here at the SECA office, which is our nonprofit for our EMS for Children program. We are looking at trying to get some type of a recognition logo that they can use on their website and for marketing to share that they are pediatric ready. And then we're also looking at doing a larger marketing campaign with press releases and different like news outlets like that. Next slide. All right, so a little bit more on our development. This is just a snapshot of kind of what it looks like. So we have our 4 levels across the top, and then we have a bunch of different categories down the side. And you can kind of see where it's standard across is in white. And then once there's a change there, it'll be highlighted in yellow. So that's something new for that level. And the other categories are listed there below. So we also have, in addition to equipment and education and data collection, we also have policies, protocols, quality improvement, performance improvement, and then community outreach. So this big draft was created and it was shared and approved by our EMS subcommittee. And then we took it to all of the directors associations for their feedback. Pediatric emergency care coordinators met and reviewed it and gave their input. So far we haven't seen any significant barriers. And then we go to the next slide. So our next steps. So how we get things passed. So we have our subcommittees create an idea, a program, whatever they want to do. Then they present it to COPAC as a whole. So at our next meeting in November, it will be presented to all of COPAC for their input and final review. Once that has been blessed, then we will be taking it to the EMS board. They meet quarterly. We'll be meeting with them in the beginning of this new year because they won't be seeing committees at their December meeting. So in 2025, their first open meeting, we will be presenting it to them. I have been updating them on all of their previous board meetings, so that it will not be a surprise to them. They already know it's coming, but we'll go through it step by step, kind of outline the program with them. And if they bless off on it, either with some edits to it or as is, then it will go through our legislative process and getting implemented in the Office of EMS for their rules and regulations. And next slide. I think that's everything. Yep, that kind of all the whole program. So any questions?
Thank you so much for sharing.
Thanks.
What questions do we have? And I didn't know if you had any questions for the group or other people who are doing EMS recognition programs, if you've come across anything that you wanted feedback on or any suggestions or recommendations related to.
I don't have anything right now, no.
Well, thank you. And then next up we have Wisconsin. And did you want to share slides or would you like me to?
Yeah, I'll just share my screen if that's okay.
Yep.
Thank you.
Right ahead.
All right, can you all see my PowerPoint?
Yes.
All right, I'm Carissa Brenner. I'm the State Program Manager for Wisconsin EMSC, and I'm going to talk a little bit about our Emergency Department Facility Recognition Program. So we go by Wisconsin EMSC Emergency Department Pediatric Recognition. Our first pilot site was recognized in January of 2023. We have a single tiered program with a 3-year recognition cycle, and right now it's voluntary participation. So our application is more of an interest form, and we kind of start there with anyone who might be interested in pursuing this process. And we currently have 7 emergency departments recognized as a pediatric ready facility. I'll go over this in more detail in my upcoming slides, but we do have an advisory board. We utilize the EMSC Advisory Committee. They have voted on our facility recognition program requirements, the documentation checklist, and then once a site review is complete, we bring those results back to the advisory committee, and they actually complete the process on voting to officially endorse a facility as pediatric ready. I'll talk about our application process and everything going forward. So starting there, if facilities are interested, all of our requirements are publicly available on the EMSC website, and that includes an overview of the program requirements and our documentation review checklist. So exactly what the site reviewers would utilize. If you clicked in to our website here, it would bring you to a PDF so you could follow through our documentation checklist just like the reviewer would. And that basically mirrors the NPRP assessment as far as points values and what we're looking for as far as requirements. On the bottom, you'll see that interest form button. That's the start of our application process. So when an emergency department contact fills out this interest form, we obviously get all of their contact information. If they're feeling like they're in a good place, they can start off by already requesting a site visit date, and then whether they'd want to go through this process virtually or in person. These are emailed directly to me once the contact hits submit, and that at that point, we just reach out and start the process of setting up an initial meeting. So what that initial meeting looks like, it's typically myself and any staff within the emergency department that feels they need to be there to really talk about where they're at in this process, because this is completely voluntary. Everyone becomes interested at a different point. Sometimes in this initial meeting, the facilities we worked with have already gone through some of our other pediatric readiness programming, so they're feeling like they're in a really good spot, and it's a matter of finding a date that works for their hospital and a conference room that's open. We've had facilities just want to wait a little bit longer and maybe go to some resource sharing before we pick a date. So once a date's on the calendar, we move to assigning site reviewers. And the way we do that is we just have a group of site reviewers who have applied for the position. And I will send an email to the group stating which emergency department is requesting a facility recognition site visit, whether it's in person or virtual, and then what the dates are to see who's available. Every site visit, we do have 2 site reviewers, and I've gone as well to all of those. And once we're all in agreement on a date, calendar invite goes out with all the logistics and a tentative itinerary for the day, so everyone is on the same page. I would say about a week, maybe 2 weeks out before that site visit, I do offer just a final check-in with the facility and invite the site reviewers as well. So if there are any additional questions above and beyond that consistent communication we've had as they've come up along the way, they can ask them. If there's a policy they want to show us that they're not 100% confident on, they can get that feedback. And really throughout this process, after they hit that interest form, we really try to portray that this process is not meant to be punitive in any way. We're really here to make sure that when that site visit comes up, there aren't any surprises, and we're all pretty sure that you're going to have the required elements that we're looking for. On site visit day, what you'll see here is just an idea of what our timeline looks like for an in-person site visit. At this point, all of our 7 EDs have requested in-person documentation reviews. No one has done a virtual visit, so not 100% sure how that will go, but so far, even our interested facilities who have not gone through and actually set a date on the calendar yet, it seems that people are very much preferring the in-person option as opposed to the virtual option. But what you'll see here is we take several hours for a documentation review, and then we do have some time set aside to discuss with the facility staff, and that allows us to discuss if there are any questions that come up. But also at the end of that site visit day, we complete a site viewer report form, which outlines the elements they did really well, but also any gaps that were identified. And those may be those non-negotiable pieces that mean we need to develop an action plan because you cannot be a recognized facility at this point, or here are just some great best practices that we think you should work on implementing and maybe how to get there. So post-site visit, like I mentioned in our itinerary, we do recap with the facility same day, and they will get the recommendations of the site reviewer same day, which includes their recommendation for facility recognition. That full endorsement doesn't come until our advisory committee meets next, and they have the opportunity to review the site reviewer's reports and the outcomes, and then vote on that facility recognition. The only thing that can really change that process is if an action plan needs to be developed. And like I mentioned before, that's going to be something that's discussed with the facility same day. We'll identify the gaps that need to be addressed. We'll work out a timeline where the facility thinks they can meet those gaps, and then do an additional documentation review of any changes before presenting that information to the advisory committee for full recognition. Once the advisory committee votes, I will send out an email with an official congratulations letter. At that point, the facility will receive access to a password protected portion of our website that has some additional resources for them, like a media toolkit, Zoom background, logos, and press releases, things like that. And then we'll work on a date where we can present them with their award, which is a plaque that they can put up within their department or wherever they think would be best. So like I mentioned, once the facility is officially recognized and our advisory committee has voted, they have access to this portion of our website. And this is new for us, so we're really hoping to build it out with some additional resources for our recognized facilities, like additional ways to show that they're a recognized facility, badge clips, door decals, that sort of thing. We're just not quite there yet. But a couple things I want to highlight. We do have some logo files that they can utilize to put on their social media posts, their documentation. They can really use those how they see fit. If they want to put them in an email signature or along with their own logo, we really leave that up to them. And then within this media toolkit, we have some social media messaging that they can utilize, some canned press releases, so they're not just starting from zero. And then also some wording for like newsletters, blogs, that sort of thing. So just to show a couple of examples of how our recognized facilities have utilized this media toolkit, this is one of our newest recognized facilities. This is Gunderson Boscobel. They utilized the messaging that we provided to them in that toolkit, the logo, so it was a really easy social media post for them. They got quite a few shares from it, so it was a quick way for them to promote their accomplishment just a couple weeks after their recognition visit. A blog post from our pilot site, Aurora Sheboygan, and then 2 local media outlets who picked up a press release that was provided when one of our facilities, Western Wisconsin, was recognized. So, and you can see a sort of a picture of the plaque that we would provide to facilities as well. But this is a big piece of post-site visit work, is making sure that our facilities are feeling like they're getting some credit for the work that they did and making sure that it's not just other EDs that know what the work they put in, it's their communities that understand that these EDs are working hard to serve them and their children. So our accomplishments so far, we have 7 recognized EDs. There's like 135 in Wisconsin that we would hope to engage with. Our first pilot site was 2023. And then we recognized our first full site in June of 2024. And then this past September, we had the opportunity to have our first system-wide recognition in September. So Gunderson Health Systems, all 5 of their Wisconsin emergency departments went through this process together. And we were able to do a combined site review with all of the affiliate EDs, which really, it was a very efficient process. And now it's providing us a good example to show other systems of how you can work together and kind of divide and conquer a lot of those policies and protocols that you can use across sites. And then we just did some additional review with some of the site-specific elements, like some specific disaster planning or interfacility transfers and that sort of thing, confirming that each facility had their own requirements when it came to things like that. So our next steps truly is just continuing to streamline this process. This is fairly new for us, and hopefully we will have a lot of engagement and traction. So we just want to make sure the way we are tracking interest, those applications, and the site reviews continue to work with increased interest. I noted there the virtual site reviews. We haven't done one of those yet, so that will be a different experience altogether, and how we're going to do that documentation review. How are we going to share that documentation? Many healthcare agencies don't like to access those file sharing platforms, Dropbox, Google Drive, all of that. So we'll really have to make sure that what we're choosing is going to work for most EDs. Next steps, number 2, sustainability. So we want to make sure we're recruiting enough site reviewers. Wisconsin's a really large state. For me to get to a facility and a site visit, it might take 6+ hours. So we want to make sure our site reviewers are located across the state. So when it comes down to that documentation review, we have someone who's close by and would be willing to take the time to drive to that facility. And we also want to make sure we're aligning and promoting with other state programs. So we've had some really great collaboration with our healthcare coalitions and our state trauma program, but it's something we want to continue with. We also want to offer more to our recognized site, and that goes right into my next piece, is this recertification. We haven't gone through that recertification cycle yet, and as a voluntary program, you want to make sure that they're feeling like this work was worth it and that they're going to go through the process again when it comes time to recertify. And then number 3 is our pre-hospital recognition. We are hoping to establish something similar on the pre-hospital side of things. Wisconsin has over 700 pre-hospital agencies, so that will be a big job to undertake, but we're hopeful that that will come once we have the PPRP data and we have a really clear idea of where our state is at. We can figure out how to implement something on that side. That's all I have. Does anyone have questions?
Thank you so much for sharing. See, there was a comment in the chat from Rachel Ford. Really liked your press releases and the media process and the information you're providing to them, that next level. Great to share. And I think we see also Kathleen has her hand raised.
Yeah, thank you so much. It's really interesting to see your map and also how you handled a hospital system. You know, one of the things I noticed from your map is like a lot of the hospitals, maybe partly through the hospital system, but other things, they're the hospitals that are not close to Children's Hospital, right? So they particularly need that. And we kind of have a little bit of something similar where some of our very first Peds Ready site here in Colorado was someplace like very far away. So, so really awesome. How did you handle, I think we've struggled in Colorado with this concept of like making sure every site shows that they've done the work internally as a hospital, not just rubber stamping a hospital system and like saying, you're all accredited or you're all, you know, Peds Ready. When, you know, we know within even a hospital system, there's real variability about what happens on the ground.
So we didn't necessarily recognize the system. We still went about it as recognizing each individual affiliate ED. So I suppose if one didn't want to participate, we would have taken them off. And that was kind of our plan from the get-go when we did press releases or even when we did the documentation review. It wasn't reviewing it for the system. We still did a review of each of the affiliate EDs. And then we did a little bit of a hybrid format. We had the ones who couldn't travel in and were off the site where we were doing the documentation review come in with a Teams meeting, so we could still see around each ED. We could see their PEDS carts, and we could tell that the staff, you know, had some of these things in place that we were looking for. You know, recognizing a system is something, and Dr. Kim's on the call, it's something we've talked about a lot. We see it as a really efficient way to do things and a really meaningful way to do things, you know, if we can impact more people at one time. But I don't think we've figured out a good way to necessarily say like all of this health system is recognized without doing an independent review of each ED's policies and protocols.
Yeah, I would like to just support what Chris had just mentioned, and Kathleen, thank you for the question. You know, I think we're moving into an era where all the systems are continually morphing and combining and joining. And I think having done number of showing about 24 EDs over the last several years to get them PEDS ready, there are a lot of work being done on each independent ED that are duplicated. And if we could address this in systems perspective, I think it would really help EDs to unburden themselves from policy reading that could be shared with an entire system. So we're we're looking to find that key, that I guess the recipe to crack them out in a systems perspective. Not to verify a system, but to verify each EDs, but using the systems, resources, and support to have each ED meet the criteria. So yeah, we're still investigating and researching this approach, but I would love to hear if anybody has cracked this nut.
Really?
Well, I'll put my email in the chat. If anyone does have any additional questions, I'm happy to answer them after the call as well.
Casey, I don't know if you will be the person to, so I'm just gonna, do you know when the PPRP survey data will be available? Just curious.
That's a great question. I think we have both Rachel and Kathleen, or Kate, you might be able better suited to answer that question.
I think any of us can. I think just Michael, from if you mean from a research perspective, it'll be quite a while in terms of state-based data. I know the EDC is working to get out state-based reports as quickly as possible. Kathleen, were you going to add to that?
Yeah, the state-based data, I talked to Hillary briefly yesterday. I believe that they had, Mike Warren at HRSA wanted to see all of that. So they've kind of prepared these reports for HRSA to review because they have reporting to Congress. And then the goal is to get that out to the states ASAP. A draft of the PPRP paper is something I put together this week, and we, have to work through the data analysis after all the data cleaning to get kind of some summary tables. With a hope of getting it, then that paper has to actually go to HRSA for review too before it can be submitted for publication. So there's a few little logistic hurdles, but we're trying to move up the timeline to that to be as quickly as possible.
Yeah, just to explain my personal interest is in getting the data to really share with our US agencies. Because I've trumped this up so big, they're really asking for like, so what, how did we do? What's going on in the States? So
yeah,
that's the biggest.
Yeah. I think one of the, the goal was always that states would have their data so they can benchmark, EMS agencies can benchmark themselves within their state system, because certain states are very different than others, like some states are just purely county based and their funding stream for EMS is very different. And a state like Ohio, which has so many EMS agencies with a real breadth and scope of, big urban fire-based versus small rural. But so within, and then every state has their own legislative kind of control and licensing process. So hopefully the state data will give your EMS agencies like some information about the context in which they operate. And then nationally, one of the challenges we have and know is the thought of putting together a document to pair with the national release of the data so people can interpret what they're seeing and understanding. So they're not comparing apples to oranges when they look at certain things.
Absolutely. Okay. All right. So we'll just keep holding my breath. Thank you.
Yeah, I mean, Hillary's not on, but I do know that the EDC, feels a little bit in a waiting game as well with HRSA because they wanted to see the information first.
Thank you.
All right. Well, thank you all for sharing again today. Really appreciate you taking the time and making those updates and being here today to share them. Always learning a lot from you all and more to come. We look forward to hearing from more of you during the November and December sessions as well. We did just want to open the floor now to any questions you may have. I also see that Julie has posted a question in the chat. I don't know if any of our presenters have thought about that or if they would like to come off mute and share a bit more about their thought process behind setting a goal or any other questions you may have.
I have a quick question. I was wondering, since the checklist is, or the assessment, I should say, is a quality tool, I was wondering if any of the states had thought about encouraging, some sort of collaborative or something like that within the state to, have the agencies do a reassessment and then have everybody take work together on that type of thing. The collaborative model seems to be highly effective in terms of getting people to work together, and also share best practices. And I was wondering if anything like that is being considered.
I don't want to put Jess Davis on the spot, but I'll put her on the spot. We were, Julie Leonard had reached out because in Ohio, they're thinking of doing something exactly like that. Jess, do you have any comments at all? We're still, I guess there's like a couple meetings in the future to kind of discuss it in more depth.
And I apologize, I missed the first half of Pat's question there. What it was
About an
collaboration.
an internal within state use of their PPRP data to kind of bring EMS agencies together to start to work on kind of QI work and things like that. Pat, did I say that accurately?
Yeah, but within a collaborative like that, you would have the potential to set the expectation, well, let's take a look at it every year. And so help to keep the momentum going as far as that's concerned, and then have people work together in various sections. Much like what's happening in the PPN with the Disaster Response Collaborative and looking at the disaster checklist and, pulling groups together around that, that effort. I think it's the engagement, otherwise this is a one and done thing. And a lot of times, people, have competing priorities, and you don't work it. You have to work this.
Right. And in Ohio, we're not, we're actually working on ED side of things right now. So I'm not sure, Dr. Aldegues, what you're referring to as far as the PPRP. But with our ED recognition program, we are working with the hospital preparedness program to try to drive up the NPRP completion rates in future years. And we're trying to get hospitals to continue taking those in the current time as well. And we're doing regular office hours and webinars, drawing up like common weak points, if you will, on the NPRP and trying and getting collaborative discussions going on how to best improve those. Also working on a library of policies and procedures, because that oftentimes seems to be a weak point, and have been tapping across nationally, trying to get a bunch of examples for those and kind of a collaborative effort to put together those best practices for the hospitals to model after, if that kind of answers the question.
I'd love to just piggyback on some of the comments too. I think most of you are probably aware of the NMSS pediatric dashboards that were just recently developed, still in development, but there are now 7 measures that currently exist and are being and are posted. If you type in Google NMSS pediatric dashboard, it'll take you to the public dashboards, and the goal is for every state to have access to their pediatric dashboards, and also eventually to link this to the PPRP readiness scores. Currently, there are 7 measures that are included in the Pediatric Quality Measures Dashboard related to asthma, shock, trauma, hypoglycemia, and the like. And the goal also would be to push this back to EMS agencies so that it's not just being viewed at the state level, but also being viewed at the agency level so that you could make improvements. And I wish Cindy were on. I don't see her on right now, but we were actually talking a little bit about this earlier today during the COPIM meeting, because we are aware that a number of states are struggling to, or a number of agencies within states are struggling to get their data back. So they may submit to NMSIS, but they don't necessarily have access to their own agency level data. So I think, two things about this. One is that there's an opportunity as an EMSC program manager, program director, to advocate that states get this information back to agencies either live or as reports, because they are intended to be made readily available. And two, I think, Pat, to your point, this would be a great opportunity to use these NMSIS quality measures dashboards to begin engaging in pre-hospital pediatric readiness work, where it will tie into the pre-hospital PEDS ready scores and could eventually tie into your recognition programs. Have you all seen these PEDS dashboards or were you aware that they existed? No.
Hey, Kate, do you know when all of the measures will be up? Do you have a timeline?
Kathleen, do you recall, I know there's the first 6 measures initially, it's 7 now. Is it 6 months?
Yeah, I think so. We reached out to Clayman just last Thursday to inquire about that and haven't heard back yet. Again, we're a little at the mercy of higher powers that be, because this is a cooperative, not necessarily agreement. I'm not sure what the funding stream looks like, but kind of a collaboration, I would say, between HRSA and NHTSA. And so there's some dollars that might be moving to kind of support this work. So they were kind of stepwising it out with their internal capacity. But the goal is that, that we have 24 that will ultimately be available. But as Kate just pointed out, like there's some work on just getting the states to be able to see their own data first. In Colorado, our own state manager can't see Colorado specific data. So a few other logistics, but any agency can certainly go see those 7 measures, and instantly, if they wanted to benchmark themselves against those 7 measures, they'd see where they would be sitting at that.
Kathleen and Kate, this is Cindy. I am remote, so I am voice only, but we did talk about it this morning and I'm in the same situation. If I want to see anything for my state in NMSIS, I have to go through the data manager and we need to work through that. And I think our EMS agencies, it is the same thing. Some of our pediatric champions or PECs are the QI officer and are the EMS chief, so they can see everything. And some of them are 3 or 4 layers down on the rank. And so they would have to go to the data manager or the QI officer to be able to see how their agency scored. Anybody in the world can go and see the first 6 measures or 7 measures. I don't think everybody even knows they're out there. We cheated. We had Caleb Ward come present to our Pediatric Quality Improvement Committee in Maryland.
Yeah, I'll share what these look like for people.
It's not cheating, but it's cool. You're lucky you have them there.
This is what the dashboard looks like. So again, if you just, scroll in, it shows the data and performance from 2022, 23, 24, and it has a drop down of a variety of measures. And you can see it'll sort at the state level, eventually by geography, urbanicity, ALS, BLS, et cetera, so that you can, begin to really track how performance is. And I think this is a real opportunity to say, okay, we want to work on, for example, epinephrine and anaphylaxis, and this is something that we think is really important, then here's an opportunity to do that. So, and it does break it down by different types of agencies.
Hey, Kate, do you know when our, steering committee for the measures might come back and take a look at where we are with this?
Yeah, I don't know. Caleb Ward and Kathy Brown are the co-leads for the steering committee. And I think they've given the recommendations from the steering committee back to NMSIS, and the hope is that these will be incorporated in the near future. And then once all of the measures are up, I think the goal was then to start talking about the actual data and seeing how we might make improvements over time.
Yeah, because in looking at the data, you know, when you start looking at the data, you always have more questions.
Right.
Yes.
You
Yeah.
know, and about the data itself and stuff. And
Well, and
I
the
I think-
performance is only as good as the documentation too, right?
right.
Right.
Mm.
I think when you start to look at dashboards, you know, they're a meta level item that has, you know, it's, as an example, what percentage of patients with anaphylaxis got epinephrine? And then it's not that high. Well, did they not get it because they got it by their family and they didn't want to give it again? Like, there's so many underlying, you know, elements to it that are tough to tease out with just like a single summative, you know, metric. But you know, I think Kathy and Caleb have had some ongoing small meetings with NHTSA leadership on these next steps for the additional items, but certainly you can reach out to them to say, you know, are you interested in bringing the group back together so people can kind of, you know, talk more about it. So.
Thank you all for great discussion. I do see a question in the chat for Kate. I feel like we may have addressed that.
I think I did. I think Caleb said they would be ready within 6 months, but again, trying to push them back to the agency level may depend on each state. And so while NMSIS might be able to create them, the question is, does the state have the bandwidth and or means to share it back?
Thank you all on a great discussion today, and again to those who shared the presentation. Do you want to share with you all the upcoming updates? Share the right screen. So we have again site share or state sharing in both November and December. If you are not on the list and you would like to share an update, please reach out to me and we can help get that scheduled. And I will be reaching out to those who are on the list for November with some additional details about slide decks and items for you to address. So thank you all, and we look forward to seeing you again next month.